Bismillahirrahmanirrahim. This is the part 2 of the lecture, the pathology. Regarding the detectable pathology on hysterosalpingiography, either we can detect uterine pathology or tubal pathology. Uterine pathology, mainly detection of uterine anomaly, presence of intrauterine filling defect as fibroid. Fibroid may be submucosal, so it appears as an intrauterine defect. Adenomyosis, uterine endometrial polyp. So the polyp and the submucous fibroid both will appear as endometrial filling defect. Intrauterine adhesions or synechia, endometrial TB, and cervical incompetence. This is what we can see on hysterosalpingiography in the uterus, but of course we see only the cavity and we could not detect the myometrial lesions or the associated pathology. Regarding the tubal pathology, we have tubal block, tubal spasm, tubal polyp, hydrosalpinx, salpingitis ism canulosa, peritubal adhesions, and TB salpingitis. Uterine contour irregularities. First of all, when you see the normal uterine cavity as we see in the first lecture, it is triangular in shape, the fundus either mildly convex or flat or mildly concave. When you find irregularity of the uterine contour, we should suspect if there is adenomyosis, uterine leiomyomas, Mullerian duct anomalies. يبقى these three will cause uterine contour irregularity: adenomyosis, uterine leiomyomas, and Mullerian duct anomalies. Pelvic ultrasound and pelvic MRI or both are often required for further characterization. An incidental finding during hysterosalpingiography that we found a mild smooth concavity of the uterine fundus, as we see in this case, and increased intercornual distance more than 3.5 centimeter instead of the more straight or convex normal fundal contour. So this is the arcuate uterus. What is the significance of the arcuate uterus? Usually nowadays it's not put in the classification of uterine anomalies, but if we put a line between the orifices of the fallopian tubes, if it is less than 1 centimeter, it is within normal. If it is more than 1 centimeter, it may be a cause of abortion or infertility. This is also an arcuate uterus by 4D ultrasound. Note here, there is marked indentation on the cavity of the uterus. Again, this is abnormal uterine contour. It's banana-like shaped appearance of the uterus, but in this case, take care that the uterus is good pulled by the tenaculum or by the pulsellum. Second, take care that it is not one orifice of a second orifice of uterus didelphys. So this is unicornuate uterus, but you must take care that there is no another one. You have to look if there is any opening on the surface of the cervix or not, and this is a point of differentiation between didelphys and bicornuate. There is two separate external orifices on the cervix from outside, external os. So this is didelphys. So in unicornuate uterus, take care, it may be one opening of two. Second, search for other opening and confirm by ultrasound. This is also from the literature. This is a case of didelphys. This is two catheter balloons are injected separately in two openings on the cervix. So again, this is uterus didelphys, and again it is nicely delineated في MRI. This is the external orifice, and here it is opening on the surface by two openings, and there is a septum also in the vagina. Here the vagina better to be delineated by gel or saline during doing an MRI. So this is didelphys. This is the axial part of the cervix showing two cervices and two vagina. So this is didelphys. Not unicornuate uterus. This is unicornuate uterus. No, it is not unicornuate uterus because it has a large cavity, more than unicornuate uterus. But one can tell me, but we see only one fallopian tube. So there is a problem here. Why there is an abnormal contour of the uterus and it is displaced to the left? Usually the uterus is inclined to the right. So if it is displaced to the left, then this is abnormality. Again, this is the control, and this is the first serial film. Here there is outpouching from the uterine cavity like this, and it is a large cavity, not like the small cavity of the unicornuate we see in the last slide. And here there is one fallopian tube. When you see that problem, there is something pushing here which causes intravasation in this part. There is something here causing extrinsic pressure on the uterus and obliterating one of the tubes. Another case, is this unicornuate? Could be, but I couldn't say. I couldn't see both tubes, just I see the spill, and this is a faulty technique. You must take early film in order to see the early filling of the fallopian tubes. But again, it is displaced and pushed to one side of the pelvis. So when to do next? When I found abnormal contour of the uterus, I must do ultrasound. I must have a look by ultrasound. In this case, when we do ultrasound, it is just a large intramural fibroid. It is a large intramural fibroid displacing the cavity to the left side, and this fibroid is vascular, and this explains why there is intravasation within this fibroid. There is intravasation. Also, there may be intravasation if there is previous operative resection or something like that. So this is just a fibroid displacing the cavity to the left. The other case, there is an ovarian cyst. There is a large ovarian cyst displacing the uterus to the left side. So when we have a uterine cavity inclined to one side of the midline, and sometimes it gives a false impression that it is unicornuate uterus, you should think either it is a unicornuate uterus, it's small in size, banana shaped, one tube apparent, or it is either displaced by fibroid or ovarian mass. In this case also, maybe there is block of the one of the tubes by compression by the mass or the cyst. Again, this is a large uterine cavity and it is pushed to the left side. But here, when we push the uterus, we found that there is two openings of the fallopian tube here. This is one and this is another one. So this is misplaced uterus, but is enlarged, and it may be due to fibroid also. Then we came to the abnormal contour due to duplicated uterine anomaly. First, we have abnormal contour either due to extrinsic compression by fibroid or mass, ovarian mass, or we may find duplicated uterine anomaly. Duplicated uterine anomaly is either bicornuate or septate, but please don't say from the hysterosalpingography. Hysterosalpingography is not diagnostic in this case. We say that it is duplicated uterine anomaly. Just here, this is bicornuate uterus. There is indentation more than 1 centimeter. It is bicornuate unicollis. It may be bicornuate bicollis or bicornuate unicollis according. So this is the appearance of bicornuate uterus, but again from histosalpingiography I could not identify. In the past, we say that if it is an acute angle, it is with septate. If it is an obtuse angle, it is with bicornuate, but unfortunately it is not so. Sometimes we found septate but with a large obtuse angle. So don't write bicornuate or septate from the hysterosalpingiography. This case, it looks like septate because it is an acute angle. But here there is also, so this is duplicated cavity. In this case, it is duplicated cavity. This is the plica palmata of the cervix, the normal, and this is duplicated uterine cavity. But take care, and this is the the control film. There is homogeneous smearing of the peritoneal folds. This contrast is in the vagina. It's nothing. This contrast is in the vagina. It is corrugated in appearance. This is the vaginal smearing after the procedure. But take care that there may be other pathology. Here we have multiple filling defects. You must take care and take many projections. So we here have multiple filling defects related to the wall of the cavity. So we suspect that they may be polypi, and on ultrasound it is septate. This is the septum. So this is a narrow septum seen, two endometrial echoes, and there is a polyp. One of the polyps appear here. So we have polypoidal thickening of the endometrium and septate uterus. Oh, what about this case? I have two endometrial, horns, but what is this? It was very odd appearance, but you have to do ultrasound. If you have a very odd appearance, you have to have a look by ultrasound. On ultrasound, there is a very large posterior cervical lip fibroid, يعني interstitial to subserous in location, and you note here it is stretching the cavity over it. It is stretching the cavity over, and this is the anterior lip of the cervix. So the contrast appear as if it is spreaded over the fibroid, so it appear by this appearance. You have also, when you found abnormal appearance, you have to take a lateral film or oblique film. It will give you an impression, what is this? You will find that there is something compressing the uterus from the other side. So then we have bicornuate uterus, but we have a large fibroid displacing the cervix like this one. This is the right horn of the uterus. So we have bicornuate with fibroid in the lower uterine segment. When the fibroid is subserous in location, it makes the cavity as if it is compressed from posterior to anterior. So it appears as if it is large in size, but it is just compressed with the contrast delineated over it. Another case, duplicated uterine cavity. I think this case secondary infertility, because we see here the the site of the cesarean section, the wedge-shaped defect. So this is a duplicated cavity. From here I can say it is septate because there is intravasation in the myometrium in that part. But again, better to look by ultrasound. So this is a subseptate uterus. The fallopian tubes are normal, but this is a subseptate uterus. In the subseptate, usually it may be not the cause of infertility, because usually the baby will take its normal position, transverse position, bypassing this septum, except if abortion occur or something like that. Another case, duplicated uterine cavity, and this is the normal fallopian tubes. So this is a subseptate uterus, but better to say duplicated cavity for ultrasound. Then we came to the end, from the contour irregularity, just we missed the adenomyosis. We will see a slide for adenomyosis later on. Intrauterine filling defect. Hysterosalpingography, when we see an intrauterine filling defect, we must do also ultrasound in order to be sure what it is the cause, either endometrial polyp, submucosal fibroid, or adhesions or synechia. These are the three pathologies that may cause a filling defect in the opacified uterine cavity. This is the typical appearance of intrauterine synechia. It appears as linear filling defect. This is a linear filling defect in the uterus with contour irregularity relatively of the uterus, another filling defect here. So we have linear filling defects. It is a cause of intrauterine synechia, and it is the first look we see before the appearance of the Asherman syndrome, like this one. In this one, we see the cervix, and the uterine cavity is markedly constricted at the fundus, very, very irregular contour in appearance, but the fallopian tubes are patent. So, irregular contour and small cavity. This is with intrauterine synechia. Sometimes the synechia is very extensive that we could not delineate the uterine cavity at all. Here we just see the cervix with its plica palmata. There is no uterus above, we can see. And on doing ultrasound, the endometrium is nearly not present. Minimal fluid is seen in the cavity, mostly due to there is obstruction. There is obstruction here. There is extensive Asherman syndrome. So this is an Asherman syndrome. So again, abnormal shape, have a look by ultrasound. This is the cervix, and this is the rest of the uterus that was not opacified by our contrast. Again, irregular contour, apparently synechia present inside, and there is the tubes are not opacified, and there is intravasation with subsequent filling of the iliac veins. So this is Asherman syndrome and bilateral blocked fallopian tubes. Both fallopian tubes are blocked, and in this case I can say that they are blocked because there is an intravasation, there is a small cavity of the uterus. In the presence of this synechia, I could think that they are blocked and not non-visualized as I always see. Again, here there is a small uterine cavity, irregular appearance of the tubes like the toothpaste appearance here and there. So this is a regular appearance of the uterine cavity. And when we do ultrasound, we just see calcific endometritis. Here there is calcific endometritis, and this is very, very common with the TB salpingitis and endometrial cavity salpingitis. This is the calcification seen on ultrasound. So this is Asherman syndrome, calcific endometritis. And here the ultrasound can detect this. So this is tuberculous salpingitis. This is calcific endometritis. What is the appearance? We have a regular contour. We have multiple outpouching from the wall of the uterus. Regular contour means either I could put the possibility of adenomyosis, but why there is constriction here? It also appears apparently as if it is duplicated uterine cavity, but it is not duplicated uterine cavity. It is intrauterine synechia. Note here, this is the normal endometrium, and the normal endometrium, there is constriction by hypoechoic band here. So it caused cicatricial contraction of the uterine cavity, so the uterine synechia could mimic in some parts duplicated uterine cavity. So this is intrauterine synechia and adenomyosis. This is also the subendometrial cysts and the heterogeneous myometrium. So we have here intrauterine synechia together with adenomyosis. This is typical for adenomyosis. This is the endometrial glands outpouching from the surface of the uterus. And this is cicatricial contraction mimicking duplicated uterine cavity. Again, typical appearance of adenomyosis. Also, there is either duplicated uterine cavity or maybe the focal adenomyosis causes extrinsic indentation on the fundus of the uterus. This is adenomyosis, outpouching of the endometrial glands, and there is increased intercornual distance and as if it is duplicated uterine cavity. But sometimes, again, the duplicated uterine cavity may, if there is extrinsic indentation on the fundus of the uterus, it may mimic duplicated uterine cavity. What about this case? The uterus is in abnormal position. Here, when we inject the cannula, I found that there is capacious cervix. Here, the cervix is capacious. There is endometrial glands, and on doing ultrasound, this is a magnified view. This is not a normal cervix. This is the internal os, and this is the uterus appear in an abnormal position, pushed out by this cervical lesion. In this case, they told me that the contrast is coming out and they could not do the hysterosalpingography. Here we put a very narrow dilator here which can opacify the cavity, and on doing ultrasound there was a large cervical polyp. This was causing obstruction to the passage of contrast and with the typical vascular pedicle sign. So this is a cervical polyp causing capacious cervix and malposition of the uterus. Another filling defect here in the corner of the uterus, when you change position or change the angle of the tube, you found this filling defect is persistent here. It is still persistent here, so this is not air, this is a filling defect in the left corner of the uterus. There is normal fallopian tubes, and on doing ultrasound, this filling defect appeared to be a polyp obscuring the left corner of the uterus. And this is the vascular pedicle sign seen well on transvaginal ultrasound. So this is a left cornual endometrial polyp. So on any filling defect, please put ultrasound probe in order to see what is this defect. Another filling defect, the filling defect usually appear better in the early filling of the uterine cavity. This is early filling of the uterine cavity, and this is the filling defect seen. On opacifying more of the uterine cavity, it starts to be obscured. But in the late film, it is also apparent here. So this is an endometrial polyp. This is a large endometrial polyp. So in filling defect, please try to take early film because it will be delineated by the contrast before the contrast obscuring the lesion. And this is vascular pedicle sign of this endometrial polyp. Here there is another polypoidal lesion. The uterus appears as if it is septated, and on ultrasound it's not septated, but this is a polyp seen in the right corner of the uterus. So this is another endometrial polyp. Okay, here is this abnormal shape again of the uterine cavity. Note here the contrast is delineating the myometrium. This is a normal finding. Sometimes when the spill occurs, the myometrium becomes delineated from outside. So this is a normal finding. It is a capacious uterine cavity, and there is a suspected filling defect here. Again, we can do ultrasound to see this filling defect with capacious uterine cavity. Think of fibroid. If you found a capacious uterine cavity, as we see in the case before, that the fibroid usually distort the cavity if it is subserous in location, make the uterine cavity apparently capacious, like that. This is a large fibroid inside. So, filling defect within a capacious uterine cavity, always think of fibroid. Here again, it is a distorted uterine contour. We have a filling defect here in the cervicocorporeal junction, and we have another filling defect here in the right uterine cord. Two filling defects with distorted contour and relatively large uterine cavity. We should think of fibroids. Here, this is the right cornual defect, and this is the cervicocorporeal defect. Here is the fibroid indenting the cavity. This is the first one. This is the fibroid indenting the cavity and displacing the endometrium. And here there is another intracavitary mass, cervicocorporeal, which corresponding to this one. So this is uterine fibroids. What about this case? We have a uterus, and this uterus show increased intercornual distance. There is indentation on the surface of the uterus. Is it arcuate or what? Again, when we do ultrasound, it is not arcuate nor duplicated cavity. It is just we have a fibroid in the fundus of the uterus displacing the uterine cavity downwards. So this is a fibroid. Again, large fibroid uterus. This is a large fibroid uterus, large cavity with extrinsic indentations. Usually think of fibroid. And it is common with the infertility. Again, in the uterine findings, post-operative findings, uterovesical fistula. You can find a fistulous communication between the uterus and the urinary bladder. Outpouching post-myomectomy. This case was very strange for me, but when I asked, she said that she do myomectomy before. So this is the site of previous myomectomy. There is outpouching due to fibrosis, and there is intravasation at that part. So this is outpouching due to post-myomectomy. Then we came to the common and the most useful part from hysterosalpingography is the assessment of the fallopian tube. The uterine cavity, usually we can assess in the uterine cavity, we can assess by ultrasound or by MRI, but the fallopian tube, the gold standard to see the fallopian tube is the hysterosalpingography. So the gold standard of the fallopian tube is the hysterosalpingography. Note here how nicely the fallopian tube is well delineated. This is the interstitial part of the fallopian tube, the isthmic part of the fallopian tube, the ampullary part of the fallopian tube. Here in the figure you see the different parts of the fallopian tube. And this is the ampullary part with the normal mucosal pattern. This is the normal mucosal pattern appear in the fallopian tube in the form of longitudinal hypodense areas present, which is the folds of the ampullary part. This folds is not well seen on the lipid contrast that we used to do in the previous era. And it is not seen in other modalities. We will see the other modalities for imaging of the fallopian tubes. So the fallopian tube length is from 7 to 14 centimeters, divided into interstitial, isthmic, ampullary, and infundibular parts. Fallopian tube abnormalities are the most common cause of female infertility, accounting for 30 to 40% of cases. Hysterosalpingography provides optimal depiction of the fallopian tubes, allowing detection of tubal patency, tubal occlusion, tubal irregularity, and peritubal disease. Fallopian tube abnormalities by hysterosalpingography Either that the tubes are occluded, and occluded fallopian tubes may be proximal or distal. The proximal is a problem to be differentiated, proximal occlusion from spasm, or distal obstruction in the fimbrial end. The most common causes of tubal occlusion is pelvic inflammatory disease, congenital anomaly, post-surgical anomaly, spasm, endometriosis. And all these, in order to see the cause of tubal occlusion, we have to do MRI. Of course, laparoscopy is the gold standard. In the presence of tubal irregularity, salpingitis isthmica nodosa is to be considered, which is a sign for TB salpingitis. And we have also peritubal abnormalities that cause the fallopian tube of irregular course, like pelvic inflammatory disease and endometriosis. And here we have peritubal adhesions or pelvic adhesions. And sometimes we name these abnormalities tuboperitoneal factor for infertility. Tuboperitoneal factor. Either the adhesions is in the fallopian tube itself or in the surrounding peritoneum. Non-opacification of the fallopian tubes can be caused either, the most common, by poor technique, imperfect straightening of the external cervical ostium, or inadequate amount of contrast in the uterine cavity. If you have an underfilled uterine cavity, you could not comment on the fallopian tube filling. Second, spasm of muscles during hysterosalpingography. One or both fallopian tubes may not fill. Using radiography, tubal spasm cannot be distinguished from tubal occlusion. This could be avoided by progressive administration of contrast media, or when the spasm occurs, administration of a spasmolytic agent to relieve spasm, helping differentiate cornual spasm from true occlusion. Obliteration is usually caused by previous inflammation or uterine surgery and manifests as non-opacification or abrupt cut-off of the fallopian tube with no free intraperitoneal spillage. And when we report that there is non-opacification of the fallopian tube. Then came the dilemma of proximal tubal obstruction. Is it blocked or spastic? Here is the normal triangular shaped uterine cavity, but the fallopian tube, only the isthmic part appear here, interstitial part only. And here there is nothing. And nicely we can see here that there is a misplaced IUD seen in the right side of the pelvic cavity. So, is it on that level I can say that there is tubal block? No. It may be spastic. Of course, that there is a part start to appear. So I have to do little pressure and see. Here, the fallopian tube start to appear. So give Buscopan at the beginning, maintain pressure and re-injection. If not seen after, write not visualized. So this is the tube. It becomes delineated well. Slow infusion of fluid or contrast material decreases pain, thus minimizing tubal spasm. When there is myometrial spasm surrounding the interstitial portion of the fallopian tube, the tube may not fill distally, resulting in imaging appearance that is indistinguishable from proximal tubal occlusion. What is the difference in this case? Here the uterus is abnormal position because there is no traction on it by the stick. But regarding the fallopian tubes, this tube appear normal mucosa, normal caliber. The course, some of you will say that it is a vertical course, but it is not a vertical course. It is due to abnormal position of the uterus. But what about the other tube? The other tube show ambulatory dilatation with ill definition of the mucosa, like cobblestoning here. This is ill-defined mucosa, but there is minimal spill seen here, and there is immediate spill also seen here. So we have unhealthy right fallopian tube. Compare with the healthy fallopian tube. Another case, Here is the fallopian tube, but it starts to dilate, and persistent contrast is seen in the control film. So this is hydrosalpinx, bilateral hydrosalpinx. There is no spill at all, so they are blocked tubes. Distal tubal block due to fimbrial adhesions. This one I show you before. This is the fallopian tubes, but start to dilate until reaching that side. Here, the fallopian tube is seen, but it is spastic. It's very narrow, and the other tube is not seen. Again, wait and see. On repeated examination, you see that the fallopian tubes start to fill, and the other tubes start to fill, but delayed filling of the fallopian tubes. This one, it shows fill, and there is no problem with it, but this one, still the contrast is retained in it. Of course, this is air bubble, and on control film, there is retained contrast in the left fallopian tube, meaning that there is block or fimbrial adhesions at this end of the fallopian tube. Left tubal block due to fimbrial adhesions. Peritubal adhesions, which make to us a lot of dilemma. Is it peritubal adhesions or not? When you found that the fallopian tube is straightened like that, this is peritubal adhesions. This is normal fallopian tube, and this fallopian tube show normal caliber, normal mucosa, but it shows vertical course of the fallopian tube. This is peritubal adhesions. Of course, it may be a cause of infertility. Here, this is vertical course of both tubes, which appear unhealthy. This is what we call, it is the toothpaste appearance of the fallopian tube. It is not healthy fallopian tube. And this other one show dilatation in the ampullary part, which is with retained contrast in the control film. So this is bilateral tubal fimbrial adhesions with unhealthy both fallopian tubes. Another case, the fallopian tube here appear unhealthy, mildly dilated, and vertical course. This is the vertical course of the fallopian tube. And on the second sequence, you found that the fallopian tube become more dilated. And there is also loculation of the dye in the control film, means there is also pelvic adhesions. So we have fimbrial adhesions and we have pelvic adhesions. Another case we have here, this is the uterus, and there is vertical course of the left fallopian tube. A right fallopian tube is seen splayed on something. When you found the fallopian tube stretched so much, then there is something stretching these fallopian tubes, and the uterus is deviated to the left side. And here the contrast show loculation. In the control film, there is loculation. So we have here vertical course of the left fallopian tube, splayed contrast around a rounded mass, and the next film show loculation of contrast. This is the typical loculation due to pelvic adhesions. And this is the cause. By ultrasound and MRI, you can see the cause for these adhesions, and this is the second cause for tubal adhesions after PID, endometriosis. This is right cystic adnexal mass with low-level internal echoes, and here it has the typical appearance of blood in MRI. This is bright on T1, shading effect on T2, so this is endometrioma. Endometriosis usually causes pelvic and peritubal adhesions, and it is a cause of infertility. Then we came to the TB, although rare, but it has specific findings on hysterosalpingography. Affection of the fallopian tubes by TB, either specific findings or non-specific findings. The specific findings is the presence of beaded fallopian tube, golf club tube, pipe stem tube, the seen in the last slide, couple stone tube, leopard skin tube, which is the couple stone appearance, like the couple stone appearance. Non-specific findings is the presence due to adhesions, hydrosalpinx, mucosal thickening, and peritubal adhesions. In the uterus, we have specific findings is the T-shaped uterus due to systolic appearance of the uterus due to endometritis, pseudo-unicorn with uterus, trifoliate uterus, non-trifoliate that we have seen in a previous slide, which with adenomyosis. Non-specific findings, endometritis, synechia, distortion of the uterine contour with venous and lymphatic intravasation. This is the different appearance of unhealthy fallopian tube. This is a cotton wool appearance. This is exaggerated cervical glands, and this is cotton wool appearance of the fallopian tube. This is beaded appearance. It's not healthy fallopian tubes. They are beaded fallopian tubes. And here thick mucosa of the fallopian, dilated hydrosalpinx with thick mucosa. This is the trifoil appearance or the pipe stem appearance of the fallopian tubes and of the uterus. All this with tuberculous salpingitis and endometritis. And the most typical is the salpingitis ethnicanodosa. We found outpouching from the wall of the fallopian tube. This is the beaded appearance again of the fallopian tube, and the retained contrast in the control film means that there is adhesions. Tuberculous salpingitis. This is the vertical course, the typical vertical course of the fallopian tubes, and here is the peritubal hollow. There's edema in the fallopian tube. There is unhealthy fallopian tubes. This is the typical appearance of peritubal adhesions. Another case, in this case, there is important finding you have to pick out that this tube is not complete. This mostly post-ectopic salpingectomy. This is only the isthmic part is seen. And here we can see the other tube show also fimbrial adhesions with consequent hydrosalpinx, mostly due to adhesions present due to the ectopic. So this is post-ectopic salpingectomy, post-ectopic with hydrosalpinx on the other side. We have different appearance also after tubal ligation. We can put these structures. It can be done under fluoroscopic imaging in order either to ligate the fallopian tube or to recanalize the fallopian tube, and this is how we place the guide wire in the proximal part of the fallopian tube. It's not done so much, but it was many people have done it as a research, and it good canalization of the tube, except if the tube itself is unhealthy after that. This is tubal recanalization. Here, guide wire, and after injection we found that the tube become recanalized. What are the imaging modalities for assessment of the fallopian tubes? All of them are of lower importance regarding to hysterosalpingography. Sonohysterography. Sonohysterography is a simple ultrasound imaging technique to visualize the endometrial cavity in more detail than is possible with routine 2D and 3D ultrasound. It can distinguish between endometrial and myometrial origin and assess tubal patency, but here only we can see the tubal patency, but we could not assess if the tube is healthy or not. In many cases that I show you diseased tube, it is patent, but it is unhealthy. Also regarding the myometrial and endometrial origin, fibroid or polyp, I think by new machines we can differentiate between polyp and fibroid without the use of sonohysterography. This is a sonohysterography showing multiple polyps, like the case I show you in the hysterosalpingography. This is multiple polyps, better seen. Also in the presence of intrauterine synechia we can detect well. This is another case. There is multiple polyps seen. And also in the presence of intrauterine synechia. This is how to assess the patency of the fallopian tube by contrast mammography, but contrast ultrasound. But in Egypt there is no contrast ultrasound widely available. using of microbubble contrast material in order to show the fallopian tubes. And here, there's intrauterine synechia, like the case I show you. The filling defect, linear filling defect, could be seen on sonohysterography. We have imaging also with CT virtual hysterosalpingography. Virtual CT hysterosalpingography is a nice technique, but not so nice because there is radiation exposure also, so we can do hysterosalpingography simple. But we can do navigation through the fallopian tube, and we can see this is a surface rendering and map. We can see also, we can do navigation within the tube and see if there is polyp, if there is synechia, we can see during CT examination. This is another case showing bilateral hydrosalpinx on CT, coronal 3D reconstruction, and it is this very nicely delineated on MIP, and we can see also the mucosa of the fallopian tubes. The merit of CT is we can see the extra luminal component. If there is fibroid or something, we can see on CT also. And then we have the MRI hysterosalpingography image, so contour irregularity. Here there is contour irregularity, and when you get to the T2 image, you found that it is a fibroid displacing the uterine cavity to one side. And this is the hysterosalpingography of the same case, showing extrinsic indentation on the surface of the uterus like that by this mass lesion. Laparoscopy is still the gold standard because we can see with our eyes if the fallopian tubes are patent or not. Normal uterus and fallopian tubes, laparoscopic image of the pelvis shows the normal appearance of the uterus and fallopian tubes. Laparoscopic peritubation image here show that the tubes are patent. And this is important if we have non-opacified spastic fallopian tubes and not blocked. Here is laparoscopy showing hydrosalpinx. And here also we have bilateral hydrosalpinx seen on laparoscopy, and usually in these cases, especially if the tubes are healthy, they do tubal disconnection in order to do the IVF after. This case also, secondary infertility for 5 years, has hydrosalpinx with thickened mucosa, and on laparoscope we see that there is hydrosalpinx here and they do disconnection also. This is another case of hydrosalpinx, and here on laparoscopy it revealed the cause. There is superficial endometriosis. Usually the superficial endometriotic patches we could not see on imaging, but they are seen on laparoscope. So hysterosalpingography and laparoscopy are complementary to each other and not competitive. Hysterosalpingography could not replace diagnostic laparoscopy, but it is the first line and integral part of the female infertility investigation. It is usually minimally invasive, rapid, and cost-effective. So they are completing each other, and the gold standard is the laparoscopy, of course. Thank you for your attention.